All right, so wake up. This is part two of VL Bougie, Pearls and Pitfalls, a deeper dive. Let's get right into it from a mechanics point of view. How I hold my bougie, I'm a believer in a naked hold. I hold it just around 35 to 40 centimeters, so just proximal to the middle of a standard bougie. And the reason why I'm doing that is so that I don't have to let go of this bougie during its placement. And I'll talk about that in a little bit more detail. There's lots of other descriptors of how you can hold your bougie and prepare it. And this has been referred to as the D grip or the Kiwi grip. And it is definitely helpful if you're a solo user. And I've talked about some of the caution that you should have in using a preloaded D grip. I'm not going to get into this in a bit more detail, but it is on our YouTube site. The important part about using a bougie is that you need to keep it anterior. You need to keep that coude tip anteriorly and not let go of it. So anterior as it bypasses the tongue, and ultimately anterior as it enters the trachea. And obviously the reason why you want it anterior is so you can get that feedback of tracheal clicks, recognizing that the rings are anterior and posteriorly it is a smooth muscle. If you let go of your bougie during this phase, then what will happen, because the weight of the coude tip, it will rotate, and it will rotate to that corner transition between the rings and the smooth muscle, and then you won't get the feedback of clicks. This is just a video I took of the clicks. I could watch this forever. You're seeing the coude tip bounce along the rings, and again, for most of the time, you should feel this in a reliable manner. There's been some literature and definitely a lot of opinion that this is the way to go, and that you shouldn't have to seek an alternative approach in terms of hold up distally. And I think that this is still a point of controversy. I'm not going to get into it in a whole lot of detail at this point. The most reassuring thing to do is actually watch it go in. You watch it go in, and then you can feel the clicks, but watching it go in is relatively reassuring. Now, hold up is something that I've heard people describe that happens at the crina. Obviously, it can't happen at the crina. It happens, this is not a bougie, obviously, but you're seeing with this endoscope that at some point the caliber of the scope in the bougie will meet the same caliber of usually a second generation bronchus. And this happens roughly at about 30 plus or minus 5 centimeters at the mouth for an adult. There's concern that this hold up, if it's done too vigorously, that it can cause trauma. And there's been reports in the literature of this happening, and many calls for abandoning the hold up sign. Again, I'm not going to get into this pro and con, but I will discuss it briefly as we move on. So what happens here from a visual point of view, again, this is just a nice image, the same one that you saw or video that you saw before. You'll see that bounce along the rings, and ultimately, almost always it ends up in the right mainstem bronchus. And you'll see this is just me going down in clinical cadaver, and you can see where that hold up happens, and it happens in a right second generation bronchus. The question comes up from a tracheal clicks point of view is that, let's say you're faced with a grade 3 A view in which the epiglottis is tilted upwards towards you, and you should have good success with blindly cannulating the trachea in this scenario. But what you want is some reassurance that you're there. And the question is, in that situation, in the height of the moment, when your heart rate is high, what's the reliability of feeling tracheal clicks in this scenario? I've discussed this before and proposed that there's something called the psychological shock index, where I heart rate, meaning your heart rate, is greater than your patient's heart rate. So you have a PSI, a psychological shock index of greater than 1. That this is not a healthy environment. And this affects your ability to perform. It affects your ability to correctly identify sensory information that may include that feedback of clicks. This is a study that we have received approval for, where we're going to look at bougie placement in the either esophagus or the trachea, and whether we can correctly identify this with associated stress. And that inducing stress will not only be just an elevation of heart rate, but some other stress. And unfortunately, we haven't been able to do this because of COVID so far, but look out for this in the future. So let's get back to the topic, which is Bougie used primarily with a video laryngoscopy. And I said in part one, the problem with the term video laryngoscopy is that it represents a heterogeneous group of devices. And even within class, such as a Macintosh or standard geometry VL device, there is considerable variability within these Macintosh blades. And this will affect your ability to use an adjunct such as a Bougie successfully. Now, there's several assumptions that many people believe are in existence regarding a Macintosh VL device. And the first assumption is that the direct and indirect, it gives you a direct and indirect option for laryngoscopy and intubation. And that's not always the case. And this is important when you're using a Bougie. So where there is variability is in blade design, lighting, camera position, and magnification. So when you use a hyperangulated VL device, when you look in the mouth with that device, you're not going to see the glottic inlet because this is a see around the corner device, as opposed to what you see here on the left, which is quite easily often you'll see a full view of the glottic inlet, and this is not a view that I would seek because you're looking up at the anterior tracheal wall, which means that you're going to require a significant curve in whatever device you're going to use, and you're potentially going to butt up against that anterior tracheal wall. The point is, though, is that when you look in the mouth, you're not going to have any view similar to what you're going to have on the screen when it's a hyperangulated VL device. Just the three most common devices that we're talking about on the market, I think worldwide, are the McGrath, so it's X blade, the CMAC D blade, and the GlideScope hyperangulated VL device. So those are the three most commonly used devices in this category. When you use a Bougie in this situation, out of the package, you will be disappointed. You might see it enter your field of view on the screen, but all that's going to give you is frustration because this is a straight device, not a see around the corner adjunct. Or work around the corner adjunct. And so don't use an out of the package Bougie unless you want to be very disappointed. When you use a Macintosh or a standard geometry blade, under the assumption that it's either going to be the same or similar on the screen as it is in the mouth, you would expect a out of the package Bougie with a coude tip to be successful. And again, each of these devices such as the McGrath Mac, the GlideScope has a Mac blade, and obviously the CMAC does too. And we'd expect that this would be similar kind of experiences you would have with a direct type Macintosh laryngoscopy. So again, these are all direct type views with a conventional standard geometry laryngoscope, and we'd expect with a VL Mac device that we would have a similar view on the screen. And this is not always the case, and I'm going to circle back to why this is important with use of a Bougie. Now, many people will say, well, why would I use a Macintosh video laryngoscope if it gives the same view on the screen? What's the advantage? And I think clearly the literature does demonstrate an advantage, and I think it's based on three factors. First is that even if it's a small onboard screen, it's a larger view on that screen than it is looking in the mouth. There's no proximal framing distraction. So when I'm looking at the glottic inlet up top, I see, the lips or a mustache, a blade, and then far beyond that, I see the area of interest. And the last reason is just that, is that you just see the area of interest with an appropriate depth and width of visual field that is helpful in delivering an adjunct or an endotracheal tube. So blade design. These are all devices that I own and they're in my office, and if you put them out there, all the blades are described as Macintosh blades. And clearly there's differences in these blades just visually looking at them as they appear here. There's other issues in terms of difference, and this is all related to the heterogeneity of within class of Macintosh or standard geometry blades. There's differences in terms of magnification on the screen and camera position, and ultimately lighting. And let's look at this in a little bit more detail. If you just Google video laryngoscope, you'll come up with all these blades. And other than the channel blades here, the majority of the blades, as you see, are described as being Macintosh blades, but there's significantly differences between one and the other. So let's start off with magnification. Some manufacturers, unfortunately, I think have got it wrong, thinking that what we want to see as clinicians is a great big glottic inlet that occupies the majority of the screen. And that's not the case, as I demonstrated earlier. What we really want is we want to have a nice depth and width of field that allows us to watch whatever we're cannulating the trachea with, whether it's a bougie or an endotracheal tube. We want to watch that approach the glottic inlet. So this is on a mannequin, but just to show you that there's differences in terms of magnification from one to the other. And if you look in the mouth, there's differences in lighting. And this lighting does have the potential to influence success if the lighting doesn't meet minimal standards that I'll talk about in a little bit more detail here. So when you look at the three most commonly used devices, the GlideScope system, the McGrath system, and the CMAC system, there is variability in lighting for what you see on the screen. And the majority of these devices were designed such that they wanted to have optimal lighting on the screen and not necessarily for a direct view. Again, this is an example of some of the devices that I have, and just on a quick visual, you can see that there is variability in lighting from one to the other. And these are the three commonly used devices, comparing it with a high-quality direct laryngoscope, as you see here on the left. Interesting, the device with the best lighting that I've seen on the market is the iView. As you see on the right. There's been some literature out there in mannequin studies comparing the illumination of the oral cavity, at least on mannequins, and all you can say really from this is that there is significant differences when you compare them to each other and a standard direct laryngoscope. When you measure lighting, there's a difference between illumination and luminance. And one of them, essentially, we're measuring the amount of light that's taken up by the surface that you're lighting. And the second type of measurement is the light that's reflected back to you. And the latter one is probably the more important one. This is a study that we did comparing various devices and measuring illumination and luminance, and we were comparing it to a standard high-quality direct laryngoscope and seeing whether these devices meet the minimum industry standard for lighting. So without getting into a whole lot of detail, in terms of illumination, the minimal standard is somewhere between 500 and 900 lux. In other words, if you were to measure the lighting of your laryngoscopes, if they were less than that, then essentially they would be taken out of clinical use. And several of these devices, video laryngoscopes, barely met this minimal standard, and this has the potential of affecting or influencing your clinical use of these devices directly. And so hopefully we've published this or presented this locally, and we're preparing it for publication and peer review, and you'll be able to see this in the near future. So again, with Macintosh video laryngoscopy, we talked about the fact that there's differences in blade design, light, camera positioning, magnification, and we're going to look at a little bit more on the importance of that direct versus indirect view, and we're going to focus on Macintosh VL standard geometry blades. So the assumption that we talked about earlier is that what you see in the mouth would be the same or very similar to what you'd see on the screen. And this study a couple of years ago that we did on clinical cadavers comparing two Macintosh-style video laryngoscopes, what we were doing is looking at what you'd see in the mouth directly with these devices, and then two other independent observers were looking on the screen, and then we were looking at what the difference was in terms of scoring of the view. And ultimately, we made the conclusion that there was no clinically significant difference. Where there seemed to be more of a difference was with the GlideScope Mac blade, and a 6.7% difference with confidence intervals from 2 to 11%. And I'm in retrospect, I'm questioning whether this was the appropriate conclusion, because I think, certainly as it relates to bougie use, this has the potential to be clinically significant, and we're going to talk about why this matters. So, a direct versus indirect view, certainly with the CMAC system, what we found in this study, and certainly with teaching using this device, you've got good brightness and lighting, and you have a similar view in the mouth as you do on the screen. But as we discovered in the study that we did, there is a difference with the Mac blade of the glide scope, and whether this is clinically significant or not is up for debate. In other words, from a camera position point of view, when you use the Macintosh blade from the glide scope, you get a slightly better view on the screen than you do in the mouth. And this might not be an issue if you're using a stylated endotracheal tube, but when you use a bougie, I think it does have the potential to be a significant difference clinically. So here we have a view in the mouth, and it's a grade 3 view, where it's an epiglottis only view. When you look at the glide scope as an example, the view might be anywhere from 2 to 11% better on the screen than it is in the mouth. And although we didn't study it, the clinical experience that we've had with the McGrath Mac is that this does, from a camera position point of view, and I think from a blade design perspective, again, you have a bit more of a see around the corner view with this device. In other words, better on the screen than it is in the mouth. Now, why does this matter? It matters if you're using a bougie that's straight out of the package, right? So on the left, we've got a direct view. On the right, we've got an equivalent view on the screen. And if that's the case, straight out of the package, a bougie should work in a similar manner. One of the points of caution is that when you are using bougies in a sim lab, they more commonly look like the one on the left. Right? And just from use over and over again, they get a gradual, what I call a pillow bend that I'll refer to later, and you get used to using it in that way. And that's a completely different adjunct than one that is out of the package. So make sure when you are, doing simulation using a bougie that you have one that is straight with that coude tip as we previously described. Ultimately, the coude tip of the bougie is really meant to manage the epiglottis. Right, your laryngoscope is managing proximal structure. So the fact that it is straight with that coude tip isn't meant to manage around the corner view. It's meant to manage the epiglottis. So not to belabor this point, but the motivation of doing this two-part series was the fact that I was receiving emails about people having challenges in using the bougie with Macintosh Blade VL devices. So part of the reason I believe that it's been a challenge for some of these people aren't getting used to transferring from looking in the mouth to looking on the screen. And this is a critically important sequence of events. So whenever you put something in the mouth, you look in the mouth. Whenever you're having problems on the screen, look back at the mouth. So I'm putting the blade in the mouth here. I always put a blade in obliquely because that helps me manage patients with big chests in which I can't position them because of a trauma. But I just do that routinely in every case. But again, obviously, I'm looking in the mouth, watching that blade tip disappear. And once that blade tip disappears in the mouth, then I transfer and look at the screen. Right, I'm doing my epiglottoscopy and ultimately a moleculoscopy. And then once I get the appropriate view and with laryngoscopy, I'm going to look in the mouth as I place the bougie, keeping it anterior and watching it disappear. And then I'm going to look on the screen as it approaches the field of view on the screen and enter the glottic inlet. And then the same thing when I place the endotracheal tube over the bougie. As that tracheal tube is entering the mouth, I need to look in the mouth, make sure it doesn't get caught up on teeth and any other structure. And then as it approaches the field of view on the screen, I'm going to watch it and preemptively manage holdup at the glottic inlet that I'll talk about in a bit more detail. So as discussed in part 1, optimized laryngoscopy, epiglottoscopy, moleculoscopy, and laryngoscopy and intubation. And laryngoscopy and intubation means doing an additional head lift beyond the ear to sternum sniff that you might have started with. Reach around with your hand and trying ELM, external laryngeal manipulation, to see if that helps, and then ultimately reaching for a bougie that is ready and waiting for you to use. So here you are, you're looking in the mouth as the bougie enters, and you're trying to keep it as anterior as you can, keeping your head down until you lose view of it in the mouth, and then you're going to transfer to looking at the screen. So you're watching it in the mouth, you watch it disappear, and then you transfer to the screen and ultimately cannulate the glottic inlet. So hold on tight. This is some advanced bougie mechanics. Some of it you may be familiar with. Some of it I don't think has been discussed in foam or in the published in the peer-reviewed literature. So the most common scenario where people are having trouble is that the bougie ends up going posterior, like heading towards the esophagus. And so why does this happen? Is this related to intrinsic anatomy, or is it something that you're not doing correctly? But obviously this is a very frustrating thing, and there are various reasons why this happens. And the most common reason, I believe anyway, relates to not problem solving at challenges that are actually happening at the mouth. So you're focused on the screen and what's going on and watching go posterior, but you're not coming back to the mouth to look at why this might be happening. So why would this happen? Why do we, when we're looking at the screen and we see it end up going posteriorly? As I said, this might be because of intrinsic anatomy, but whenever you're having a problem, I said there's two situations where you got to look at the mouth. One is whenever you put something in the mouth, you look in the mouth, and then whenever you're having a problem on the screen, you need to look in the mouth. So I call this paradoxical posterior deflection. And as what was happening before in that video, you can see the bougie, it's actually pivoting on proximal structures and here in the teeth. And you won't identify this unless you look from the screen back in the mouth, because you are having problems on the screen, as we've talked about. So this is an attempt of me demonstrating what's happening. This malleable piece of metal there is meant to imitate the teeth, and you see this pivot. It's happening on the teeth there and then on the posterior tongue, and that leads to that paradoxical posterior deflection as you see here. And the only way you're going to identify that is if you look in the mouth, if you're having challenges on the screen. Now I want you to take notice of where the bougie is, and the bougie is entering more midline. And this is one of the ways in which you problem solve this. When you place an endotracheal tube, you'll usually place it from the right corner of the mouth. And this allows you to avoid the big incisors. So as you see on these images, and you'll see on this video, I'm entering from the right corner of the mouth towards the midline. That keeps me away from those big teeth and less likely to run into a problem in terms of pivoting and that posterior deflection that I talked about it. So there's issues related to entry, and it's not just entering from the corner of the mouth, but you need a direct view, right? So you have to manage, you have to have adequate mouth opening, you have to compress the tongue, and you need to manage the epiglottis. And in doing these things, plus appropriate positioning, as using the terminology that Keith Greenland uses, as opposed to aligning the axes, here what we're doing is flattening the two opposing curves. The primary curve, which really is the go around the tongue curve, and then the secondary curve, which is from the posterior pharynx entering the trachea. And you have to manage these curves to be successful in using a direct type of device, whether it's a direct laryngoscope or a Macintosh type video laryngoscope. So there's entry issues. And then additionally, there are view mismatch issues that I talked about before, where Macintosh blades are really behaving somewhat like as a Mac Plus type blade. So they're doing a little bit of a see around the corner, usually because of camera positioning on these devices. Now this doesn't matter if you're using a styleted endotracheal tube that is shaped as a hockey stick. Now this is a point of contention for me, because at least in the airway world, a hockey stick curve is really described as a 90-degree bend. And yes, I'm gonna stress this, but a true hockey stick actually has about a 30 to 35 degree bend, which is the optimal shaping that you would use for a standard geometry Macintosh blade, whether it be video or with video or without video. So this is an important distinction. So a styleted endotracheal tube, shaped as you see here, can navigate around the corner. It can navigate around the tongue and also manage epiglottis issues, as opposed to a bougie, which really can't manage the around the corner issues related to the tongue. So this is not a clinically significant difference when you use a styleted endotracheal tube, but this has the potential, this view mismatch, to be an issue if you're using a bougie. And the only way I think that you can assuredly use a bougie when you have this view mismatch is to put some sort of additional bend on the bougie. And the additional bend you're doing not to manage the epiglottis, but to manage that a bit of a C around the corner that's ultimately happening that's causing a challenge. And I call this a pillow bend. So it's almost all disposable bougies that I've used. You can essentially take them out and flex it on a pillow or on the bed, and you'll get this maintained curve that will facilitate entry, right? So here you're going to see a pillow bend. So it wasn't successful. I come out and I'm just flexing it on the pillow or on the bed, and then I rotate it in place, looking in the mouth, and transfer to the screen, and presto, there we have it, easy entry. So if we have no mismatch, such as this scenario, then an out-of-the-package bougie will work, right? Because we don't really have to manage going around the corner, around the tongue. We just have to manage the epiglottis, and that coude tip will be able to help us manage that scenario. However, if the view is greater on the screen than it is in the mouth, it means that your device is performing with a bit of a see around the corner type of advantage. And that is only an advantage if you are using a adjunct such as bougie that has a bend, or using a styleted endotracheal tube that helps you manage that primary curve, that see around the corner effect that is happening. So these are just some comparisons of the same bougie that has been manipulated. So on the bottom you have an out of the package straight bougie. The next one is a pillow bend that I've demonstrated. The next one up is a deliberate bend that I'll show, and the final one is a steerable tip bougie. So a deliberate bend is a scenario where you would get somebody to hold the bottom, say 20 centimeters, I can't tell you exactly what portion it is, and they're holding in this manner until you're going to use it. And this deliberate bend is a scenario where potentially you can use a bougie with a hyperangulated VL device. Now, in the past, we've said, and we still say, that it is inappropriate to use a bougie out of the package with a hyperangulated VL device, right? For all the reasons that I've talked about over and over again. Even here in this scenario where we've got a pillow bend, that pillow bend will usually not be enough to manage the hyperangulation, see around the corner effect of this type of device. However, if you use a deliberate bend, and that deliberate bend just gives more of a distal angulation that mirrors the curve of the hyperangulated device, that you will be able to cannulate the trachea in the snare, recognizing that you might run into the same challenges where that additional coude tip will get caught up anteriorly, either on the cricoid ring or on tracheal rings. Usually this is manageable. So a steerable bougie is out there. I've played with it. It is kind of fun, and essentially it has somewhere between what I would call a pillow bend and a deliberate bend that's already built into it out of the package. And then on top of that, you have the ability to steer the distal tip up and down. I'm not going to go into details about this, but it's not too crazy expensive. 10-pack for 189 US dollars, at least where I could find it. These might be Australian dollars, I'm not sure. And we're starting to see a couple papers in the literature describing its use. So let's finish off talking about some tube over bougie issues on entering the mouth and entering the trachea. So again, I said if you're running into a challenge and your bougie is not, your tube is not advancing over your bougie, then look at what's happening in the mouth. And often it's getting trapped at the teeth. And this is something that is easily overcome, again, by looking at what's happening in the mouth. So the other thing is somebody will be holding the bougie proximally to prevent railroading that bougie and you getting distal holdup and theoretically causing injury. And it's important that they hold it in its natural lie, and that they don't hold it from below the head and neck, because that creates a curve on the bougie that can cause a challenge in moving that tube over the bougie. So avoiding a difficult tube delivery. 3 things you need to do is remember is that you need to continue laryngoscopy as you advance the tube over the bougie into the trachea. You need to often problem solve at the glottic inlet by performing a counterclockwise rotation of the tube as it passes through the glottic inlet, or use an alternative tube. So why do we continue laryngoscopy? It's pretty simple. That if you don't do that, just because of the positioning and not managing the tongue, sometimes the bougie will fold in the posterior pharynx and the tube won't advance easily, right? So that is easily managed by doing laryngoscopy as you proceed. Remember that the bevel is leading edge of the bevel is towards the right, and you're working out of the right side of the mouth, and that leading edge of the bevel can get caught on right-sided structures, and you manage that by rotating it counterclockwise, which brings that bevel towards the midline, as you're going to see in this next video here. So what you see in this scenario is problem solving when you have an issue. So it's banging on right-sided structures and then taking them off, pulling the tube back, and then rotating counterclockwise, takes a bevel off those right-sided structures, and the tube sails in. But why wait for that? Right? So why don't you do this preemptively every time? So just rotate that tube counterclockwise before you run into issues. So every time you're using a bougie, you do that. I think this is an important point to stress. When we're running into challenges and you'll learn, okay, this is what I do when I run into this difficulty, that's great, but you have to remember to do that. And so this is what we call a cued response. You have an issue that arises, and that cues you to do a certain response. But if you preemptively manage difficulty, then you won't have to wait for that cue, which is sometimes hard to process when you're stressed out. So the last thing, there's keep the laryngoscope in, there's counterclockwise rotation, or you can use an alternative tube. And that alternative tube could be a Parker flex tip tube, and the basic principles are, what this tube is, that the bevel is anterior and has this little bird's beak, which decreases the transition point between the tube and a normal tracheal tube, as you see here on the right. Where you see this on the left, the bevel is anterior. It's not going to get caught up on right-sided structures, and you don't have that transition holdup between the outer diameter of the tracheal tube and the bougie. So these are the things that you can do to, I think, avoid challenges that you can run into when using a bougie with Macintosh video laryngoscopy. And the literature has demonstrated there's a lot of success with using a bougie, as high as 98% first pass success. But as I said in the part one, this is not just about the bougie. This is about the whole package, and learning and how to optimize your laryngoscopy, learning how to problem solve challenges. And it's just not simply picking up a bougie and using it. And we know that if we employ, change in quality assurance programs, whether it's using video laryngoscopy or laryngoscopy in general, that we will improve intubation success. So it's not about the device or the adjunct. It's about the hands that use it, and it's about the team that supports those hands. That's all I've got to say. Thanks for your attention.